Good evening. Thank you for joining us. In our last program, we discussed irregular heart rhythm, something that affects millions of people. Arrhythmia is when the heart beats too fast or too slow, or when skip beats. It can be life-threatening, causing your heart to stop or stop pumping enough blood to your many important organs in the body, including the brain. It's a very big subject with many components affecting many people so much. We decided to devote 2 shows to the subject. In our last program with Dr. Yosouf Kanjawal, our expert at the time, we learned the causes of arrhythmia, such as coronary heart disease, electrolyte imbalance changes, and changes to your heart muscle itself. Just to name a few, we learned about the symptoms such as palpitation of the heart, pounding in your chest, dizziness, and shortness of breath. Each one indicate your heart's rhythm is irregular and could lead to a serious consequences, including possibly stroke. We also learned about the test used to determine the exact causes of those problems, such as EKG or electrocardiogram, Holter monitor, stress test, and echocardiogram. All very important in determining the treatment. And that is where we begin today. How is arrhythmia treated? That's next on Time Waits for No One. Which brings us really to the treatment, and like what you said, other than the medicine trying to slow the heartbeat or get it under control, you put them on the blood thinner now, which is another big dilemma the patient has to face. And there is a specific reason for that blood thinner, which is to reduce the chance of stroke.
Absolutely.
So we always get that question that what is the difference between using aspirin, which is a blood thinner, versus using the very strong blood thinner, which is like the Coumadin on the other end. Can you explain why we differentiate between the two based on the patient condition?
Correct. It's a very, very important question, and a lot of times people will ask this question that why can't I take aspirin? Let me be very clear to the people, that as far as the prevention of stroke and atrial fibrillation is concerned, aspirin was found to be equivalent to placebo. Means basically, if you take aspirin, it does not prevent you from having a stroke. Number one. Number two is there are blood thinners, and some of them are older ones, the time-tested, what we call Coumadin. And that is usually considered as a rat poison because this was used as a rat poison in the past. Now, I would stress upon the people who really need these blood thinners or the people who have more risk factors. So what we do, we categorize. In America, we call it CHADS2, if the lay public doesn't understand that. But the more risk factors you have, the more chances that you are going to get a stroke. For example, high blood pressure. For example, diabetes mellitus. If your age is more than 75. If you had stroke or a mini stroke, what we call TIA, or you had, I already said about diabetes as well. So we call it CHADS. The more score you have, the better is that you better take an anticoagulant, or we call blood thinner. And Coumadin is time tested. The only problem with Coumadin, as all of us know, that you got to get that level, which is really a big hassle for some of the patients. That they either cannot take certain medications or food. There is a lot of medicine to medicine interaction in these people. Sometimes their blood can get too thin and they can bleed, or their blood can get too thick, and then the advantage of taking that medicine doesn't exist for that matter.
And that's why really monitoring that Coumadin is so important. I mean, the patient is not only taking the medicine, it's not aspirin.
Correct.
They have to have their blood checked sometimes every week, most of the time every month.
Right.
They have to adjust their lifestyle to what they eat and what they drink based on that. It's still no question about it, despite the hassle, when we look into the benefit of that medicine,
Correct.
preventing stroke and reducing the chance of having a stroke, it's still a great medicine,
Absolutely.
no question about
Absolutely.
it. Now, we're talking about Coumadin. It has all of the difficulty comes with it as a package. Now, there's a newer blood thinner,
Correct.
which is probably not as bad as the Coumadin from uncontrolled circumstances. It's available now in the
Correct.
market. Can you
Correct.
give us some idea
Absolutely.
about it?
In the last few years, there has been many drugs which have come into the market, and there have been some excellent trials, from this country particularly, which have shown the superiority of those medications vis-a-vis Coumadin. And they actually had a head-to-head comparison with Coumadin, and they found that the stroke rate was much lesser with these medications, and the bleeding was as good or as bad as with Coumadin. So we have got I don't want to be sort of a spokesperson for some of the industries, but we have some oral anticoagulants, we call it, which are different than Coumadin. They work in the cascade of coagulation we have. There are some factor 10A and other antagonists, we call them, and they can actually be taken. And the beauty about that is either it could be a once or twice a dose, but one of the wonderful things with these medicines is that you do not have to check your blood. So there is no blood checking, and that's why I think it makes sense that all these guys who are taking Coumadin, personally, as from my personal experience, should be actually taking the other drugs because of the convenience, because of not doing these blood tests, which most of the people really get scared of doing it, and they have to travel and get all that stuff done. So I would recommend that we have enough data now that about the superiority of these newer blood thinners, we call them, as compared to Coumadin.
Sure. But also, despite that, there is some limitation for those medications.
Correct.
Like you
Correct.
can't use it in people who
Correct.
has valves problem.
That's exactly
extensive
right.
valve problem.
Exactly. And then we do not, as of yet, have an antidote. If there is a bleeding from those medications, we do not have something to reverse the effect. While as with Coumadin, we have vitamin K, for example, we could. So.
Now, that's when it comes to the blood thinner and how important it is. Do you mind to tell me what's the percentage of using the blood thinner for the patient with atrial fibrillation? Like how much reduction in the stroke possibility in those patients? I know the number, I just want to hear it from you as an expert.
I mean, we have seen that, it's not completely 100%. The reason is because we don't monitor them on daily or minute-to-minute or hour-to-hour basis, that how their blood is either thin or how thick the blood is.
Sure.
So there might be some patients, actually in some of the trials they found that those people who were religiously taking Coumadin or the blood thinner, the old one, their level of thinning of the blood was not adequate, almost in 30 to 35% of the patients. So if you ask me that how many people you can save from getting a stroke, would be around 70–80%.
Yeah, which is tremendous. I mean, to reduce the chance of having stroke by 70–80%, that's a huge advancement.
The Afib treatment guidelines for healthcare providers recommend a comprehensive approach to treating all the risks of Afib. The guidelines prioritize 3 treatment goals: rate control, maintenance of normal rhythm, and stroke prevention. Healthcare providers may provide a range of treatments to jointly manage the different risks and symptoms of Afib. There are a number of ways that Afib is treated. Your doctor may prescribe a medication to slow down the pace or rate at which your heart beats. Notice that the rate medication slows down the heart rate. However, the heart continues to beat irregularly and out of rhythm. Rate control medications do not correct the irregular heart rhythm associated with Afib. They slow the heart rate down, but don't address the irregular rhythm or pattern of Afib. Your doctor may recommend a treatment designed to more specifically address the rhythm of your heart. When rhythm control medication is used, the heart beats in normal rhythm, but remains fast. Rhythm treatment regulates your heart rhythm, but may have little or no effect on the rate at which your heart beats. Combination of rate and rhythm control treatments may be recommended to reduce the heart rate and maintain the normal heart rhythm. Rate control medication is used to slow the heart rate down. When rhythm control is added, the goal is to have the heart beat at a normal rhythm.
On top of the blood thinner and the medication we use for atrial fibrillation to control it, we go into the further advanced treatment. So the first time, sometimes we tell the patient that you need a cardioversion, or that electrical shock, I call it, to the patient. Do you mind to tell us what is that treatment or how it works in atrial fibrillation?
Absolutely. Good question again. The cardioversion is basically we electrically try to get these people who have atrial fibrillation, or for that matter any arrhythmia, but here we are talking about atrial fibrillation, to get them back into sinus rhythm. Unfortunately, most of the people, even some doctors, have this notion that cardioversion converts these people 100% of the times. No, it doesn't. If you see immediately, actually 20% of the patients within, you have seen so many times, they go back into atrial fibrillation. So cardioversion is that it's again fasting, patient comes, it's an outpatient procedure. It looks like, the name itself sounds very strange, but it is, I can tell my audience that there has never ever been a death because of cardioversion. So it's not electrocution, it's cardioversion. So what do we do? We put patches and we get them, out of it by giving them a shock. It depends upon how many joules the patient needs. Usually what we do, cardiologists particularly, what we do, we put them on a medication which keeps them in rhythm. So shock will get them back to rhythm, but there has to be something on board which actually maintains that effect of the shock. And usually we give them what we call antiarrhythmic medications, which are specifically given to these patients to maintain that rhythm. And the audience will agree, they might be knowing some of the names of the medications like Sotalol, like Arrhythmia, like flecainide, like amiodarone and all that. So some of these medicines also have to be on board to keep these patients in rhythm.
During electrical cardioversion, electricity is used to fix the electrical problem in the heart. To begin the procedure, a patient will lie on their back while the doctor places either 2 paddles or large sticky pads on the chest. Once the equipment is properly positioned, a low dose of electric shock is given to the heart through the paddles or pads. This is much milder than the jump start-like shock that you may have seen given to actors on TV. The heart will begin to beat again by itself after the shock, hopefully resuming a normal rhythm. If it does not, a second shock may be given.
And that brings us really to the more advanced technology, which is in the last probably 5 years, it's becoming so advanced in helping our patients and providing a better care when it comes to atrial fibrillation, what we call atrial fibrillation ablation. Do you mind to define to us what is that treatment? What's the definition of ablation?
Correct. Ablation, which is what we call radio frequency ablation, or we these days use something like a freezing, we call it cryoablation. What it is, the concept was basically, when I was a medical student, I can tell you that, we thought that maybe
that
when you were,
last year, right?
that's many, many years ago. I don't know about you, but at least about me. What happened is we were told that this atrial fibrillation comes from the upper chambers. A lot of times we did not know whether it's coming from the right upper or the left upper. Till early 90s, somebody from France actually, his name is Michel Hesseguier, who first time documented that it is actually coming from those tubes. These are the tubes which bring fresh blood from the lungs to the heart on the left side. We call them pulmonary veins. And there is a trigger in that which comes out and which puts you into atrial fibrillation. So the ablation is basically, the people in the past used to do burning or cauterization on either right side or the left side, and it would take hours, 10, 12 hours, you can imagine that, till we found that the trigger is on the left side, and particularly from those veins we call pulmonary veins. So we go and we actually meticulously go to the left side and we zap around the mouths, we call it, or the holes around those particular tubes, and usually you'll be surprised that the patients go into sinus rhythm. What do you do with this? You basically take care of the trigger. Once the trigger is not there, once you have disconnected those things from the main chamber of the heart, called as left side of the heart, you stay in rhythm.
The number of catheters used during EPS depends on the type of study being done. Usually, 3 to 5 catheters are used. Once the areas are numb, you may feel some pressure or slight discomfort as a needle guides an introducer into your vein. The introducer provides a pathway for the catheters to be put in. Your doctor will then begin the process of guiding the catheters into place while watching them on a special X-ray screen, like a TV screen. Sometimes placing the catheters is slow and takes a long time. You will not feel the catheters as they move through your blood vessels. You may feel a skipped heartbeat, a fluttering or a pounding in your chest when the catheters move through your heart. This is because the catheter is actually tickling your heart. When in place, the catheters will sense the electrical signals in different areas of your heart. Your doctor will view these signals on EKG monitors. Since it is common for abnormal heartbeats to come and go, your doctor may try to trigger them during the procedure under controlled conditions. By doing this, your doctor can study your abnormal heart rhythm, or arrhythmia, and identify the location in your heart that may be causing it. After locating this area, your doctor will determine which treatment method is possible. The decision is based on the location and type of the abnormal beat. One possible treatment that uses radio waves is called radio frequency ablation, or just ablation. During ablation, your doctor will guide a special catheter to the area in your heart causing the problem. The catheter tip heats up and gives a small burn to the area, which safely scars it so it cannot send the abnormal signals. In doing so, ablation usually stops the abnormal heart rhythm without damaging the heart. You may feel some discomfort during ablation, but the procedure is not considered painful. After ablation, your doctor will try to re-trigger the abnormal heartbeat. If the abnormal beat cannot be triggered, the ablation is considered successful. Another possible treatment is drug therapy. Different drugs can be given through your IV to affect your heart rhythm. Your doctor will observe your heart's reaction to different drugs and discover which drug best corrects your abnormal heartbeat. When the procedure is complete, you may feel some discomfort as the catheters are removed and pressure is applied to the entry sites.
In that situation. So ablation, as per the layman, is basically the cauterization, or you may call it burning, of some of the circuits which are responsible for causing atrial fibrillation in these
now,
people.
we always face that dilemma. Not every patient is a candidate to have ablation.
Correct.
And do you mind to give us a general idea?
Absolutely.
I know it's not easy to cover that concept, but a general idea, which are the most appropriate patient to go for ablation in general?
There are guidelines. The American College of Cardiology, the Heart Rhythm Society, and the European Society of Cardiology have clear-cut guidelines for atrial fibrillation ablation. Now, there is something called, they say that sinus rhythm means the normal rhythm begets normal rhythm, and atrial fibrillation begets atrial fibrillation. So if you get these patients back into rhythm sooner, they will stay in rhythm for a long time. But if you let them go into irregular heartbeat for a long time, whatever you may do, there are structural changes in the heart itself like a scar and all that, they never go back to. So it is very, very important for the audience to know that if you have atrial fibrillation and if it comes once in a while and then goes back into rhythm, we call it something like paroxysmal. Those are the best candidates for this particular procedure. When you go for a prolonged period of time, let's say we call it persistent, and there is something called as a long persistent, or for that matter chronic atrial fibrillation, those are the guys you should not. Those, for example, somebody is in AFib for years, he's not a good candidate. So the ideal patient, what Dr. Kabour you asked is, who are the people who should go? If your age is less than 75, number one. Number two, if you are very symptomatic, and I don't know how many patients you must have seen in your practice that patients are in AFib, they don't know anything about it. So if you have symptoms of fatigue, symptoms of shortness of breath, symptoms of palpitations, if you have those symptoms, that's number two. Number three, if you have failed one medication, and it's not beta blocker or let's say antiarrhythmic we are talking about. So those things, those drugs which are given specifically for this condition, if you fail one, these are the guys who are ideal. And also you can do an ultrasound of the heart to look at the size of that upper chamber. The bigger it is, not good. The smaller it is, much better chances of staying in rhythm. And the chances of, if we do in this particular group of patients, around 80% chance that they will stay in rhythm after the first ablation.
80%.
75 to 80%.
Which is really
very good.
A good percentage. I mean, we hope that, I wish all of the patients would be a candidate for the ablation, because in that case we're curing the problem. But that brings us to the second concern, which is some of the patients when we are talking about ablation, radio frequency, and freezing. And the first other question comes in mind: what are the possible complications? Because this is interventional procedure, invasive procedure, no matter what.
Absolutely. Again, wonderful question to ask, and this is what the patients always would. I would ask patients to ask their physicians to ask, how their success is, what kind of complications you are going to anticipate. So, because every invasive procedure, as you said, has its own complication. Starting from the groin, there could be a little bit of bruise or a bleeding, and we thin the blood during the procedure. So it could be that, number one. Number two, when we make the hole in the heart itself, I mean, a lot of people get scared of, but they should be reassured that we got almost 4 or 5 gadgets in the laboratory itself which direct us to make the hole at the proper place. So sometimes you can have maybe the needle or something can go around and cause blood around the heart. It's not a catastrophic complication, but can be potentially dangerous, and we recognize it right there and take care of that. So whenever you are working on the left side, there is always a chance that, God forbid, somebody may get a stroke. The chances of heart attack are not as bad. So stroke is there, bleeding around the heart, and then one of the complications which I always talk to my patients would be the esophagus, the food pipe, is behind this particular chamber. So once we're doing the cauterization of that particular area, there is a chance that we may injure that esophagus. And it is luckily a very rare complication, and can be easily avoided because we put usually a probe in the food pipe to monitor the temperature, whether you are doing radio frequency or you are doing the freezing. So we can avoid some of these complications by meticulous attention.
After doing this procedure, I have no doubt that these patients has to have a regular follow-up, monitor their rhythm on a regular basis, and maintain their treatment. And then they come to you immediately after a few weeks and tell you, when are we going to stop the blood thinner?
Correct.
So do you mind to shed the light on that issue?
This is the tough question to answer. I can tell you that most of the EP docs will tell you that this is really, there is no consensus yet. But you're right, Dr. Kabour, that a lot of patients basically want to get this procedure done to get off the blood thinner. But I have a message for them. I cannot promise them that they will be completely going off the blood thinners particularly. So what the protocol this time is, for the first 3 months, we usually keep them on the medications, the antiarrhythmic, which we call, and we also keep them on blood thinners. These first 3 months we call is honeymoon period. So they may actually go in and out of AFib. They should not really worry about it. This is part of the process, the bruising, the healing process in the heart itself, that they may go in and out of it. And sometimes we might have to get them and shock them because we want them to be in rhythm after the procedure. So don't get disheartened that you're going back. But after the 3rd month starts time 0, that if you get irregular heartbeat only for 30 seconds, we call it recurrence. We call it that it has happened again. So at the end of 3 months, what I would suggest that if your CHADS-2 score, which we discussed earlier, if you do not have a risk factor, high blood pressure, diabetes, age, stroke, and congestive heart failure, you can probably stop anticoagulation at that time and stop the antiarrhythmics also at that time. You can take a chance. But if somebody has got somebody had a mini stroke or had a stroke or has got hypertension, diabetes, heart failure, I would prefer at least to tell them take it for a longer period of time till the consensus comes that, you know what, that you have to stop it because you no more have it.
So there's no real studies.
There is absolutely
a large population where we can
correct.
depend on that statistic to say we can or we cannot up to this date. I mean, maybe in the future that will happen. And the majority of the patients which we have with atrial fibrillation usually have quite few of those risk factors. So the message probably they're going to be on the blood thinner for a long time in general. Now that brings us really to the bigger question, which is I always try to educate the patients that when you are trying to go to a specialist to deal with a specific problem, you always ask about their credential and about their expertise. And I want to emphasize on that not every electrophysiologist can do ablation. Absolutely. At the same time, not every cardiologist can do ablation. Otherwise, I would be the first one to do it. So, so in reality, we need always to ask for the specialized individual who is trained to do this procedure, who has experience to deal with it, deal with the possible complication, but at the same time, to have a better success rate on the long run.
Absolutely.
I really appreciate it. I think we educated the patients enough today, and we're going to see you again and again and talk about different other arrhythmia problems, and I really appreciate it, and thank you very much.
Thank you for bringing me in. I appreciate it.
After listening to Dr. Kanjawal comments and discussion about heart rhythm problem, I hope you have enough knowledge about dealing with this problem. But always remember that when you have irregular heartbeat or palpitation or arrhythmia problem, please talk to your doctor. Talk to your family doctor, who I always call him the captain. Talk to your cardiologist and try to understand your problem. Because understanding your medical issue, it will be the best way to deal with your medical problem. It's so easy to deal with that problem when you are able to understand the problem. For that reason, remember that this is our goal, is to educate you, to improve your knowledge, at the same time, try to improve your quality of life and live a happier life. Because remember, time waits for no one.